good afternoon. It's not quite the afternoon yet in the UK. I'm in Glasgow, and as you can see from my opening slide, it's always as sunny as what it appears to be in my slide. Well, actually, when I look outside today, it is sunny. No, I'm delighted to be back. It's just a pity that I'm not sampling the fantastic hospitality that I experienced last year in Vilnius. But thanks a million, Paulus, for the invitation once again. Now, what I'm hoping to do is for the next 45 or so minutes, I'm going to talk about some work that we have been doing, really trying to understand the impact of COVID-19 on people's suicidal thoughts and suicidal behaviour. So I'll focus in on work that we've done, as well as then look at work that others have done, not just in the UK, but looking then at work that people have done trying to understand the impact of COVID-19 on actual suicide rates. And Paulus mentioned, I just heard him say again, that there's obviously some signals from Lithuania that during the summer there has been an increase in suicide. And I think as we look at the broader context, the broader impact of COVID-19, I think one of the clear messages has to be that although certainly in the UK, when we first encountered the pandemic, the whole message was we are all in this together. And that sense of collective action was part of the UK government strategy of trying to protect people in terms of from the virus itself and then people's mental health as we move forward. Now, what our data, and you'll see here, I'll touch on, you can see from the outline slide, our data and the other data I'll report today make it very clear that we are all not in the pandemic together, and that some groups of people are more at risk than others. And Paulus mentioned women in particular, and as you will see, our data and the other data I will talk about today tell that similar story. So in essence, the talk is in two parts. Most of the talk is focused in on this sort of work that we and others have been doing in the UK to try and understand the impact more generally on mental health as well as on suicidal ideation. And then the second bit of the talk towards the end is really trying to get some sense of what the trends in respect of the pandemic, the impact of COVID on suicide rates across some countries here. I'll focus in on 3 high-income countries. But again, when we're looking at the relationship, we need to try to disentangle the impact in high-income countries versus the impact on low-income countries. But what I would like to do, just by way of scene setting, is take you back to March, April. So in March and April, when the pandemic really hit in Europe, along with my colleague Emily Holmes, who's a British individual, a British lady who lives in Sweden, but Emily and I, together with 2 psychiatrists, Matthew Hothoff and Ed Bullmore, we were part of this core group of researchers who were convened by, in the UK, the Academy of Medical Sciences, and MQ, who are a mental health research charity. But what we were trying to do in those sort of very early days of the pandemic, when it was so uncertain what the nature of the disease was, but all of the efforts in those early weeks, understandably, was on keeping people safe from the physical consequences of the virus. What we were keen to do in this paper was the result of it, was we were keen to publish a position paper, which we were initially for the focus or the attention of UK stakeholders, but we were keen to ensure that mental health was seen as central to the COVID-19 response. So yes, of course, we had to protect people from the virus, but then the challenge we all have been living with since has been all of our different governments responding with social distancing measures, with national lockdowns, with local lockdowns and other restrictions, We wanted to ensure that we ensured that we understood the impact of COVID-19 and these restrictions on people's mental health. But for us to do that, we had to obviously be able to track people's mental health and well-being. And to that end, one of the key focus that we identified in that paper was, in terms of urgent, immediate actions, it was important for us to improve monitoring and reporting of not just suicide and self-harm, but a whole range of indicators of mental health, including anxiety and depression, and then other indicators such as defeat and entrapment, for example, which derive from my model of suicide, the Imd Model. But I suppose our point here was, if we can monitor and have an idea of who is most at risk, who is most vulnerable, we can then obviously tailor interventions. We can either repurpose interventions, existing interventions for the most vulnerable, or we can develop new interventions. So that was our sort of rationale, as you'll see when I talk about this UK mental health tracker study that we have been conducting since then. But also at the same time as we published this position paper in Lancet Psychiatry on the mental health effects more generally, along with David Gunnell and a number of other colleagues. So David Gunnell, Professor of Epidemiology at the University of Bristol, along with a number of us, we then set up what then became the COVID-19 Suicide Prevention Research Collaboration. And in essence, what we were trying to do there was focus in on what can we do to mitigate the risk of suicide. And I suppose our message when this was published in April or May, I can't remember which month it was published, but we were trying to then help not just set the research priorities for suicide prevention, but also help governments and all other organizations and other people understand how we can intervene to obviously mitigate risk. Because at that stage we were still saying, and it's still hoping, that there would be no imminent increase on suicide. And as we'll see from some data I will show shortly, in those early months of the pandemic, the data were largely reassuring, but we wanted to think in the longer term, especially when we think about the economic impact. And so what this slide does here is identified, as you can see here, basically 8 areas of potential intervention. But again, across each of these areas, we're trying to identify who is most at risk, who is most likely to be affected across each of these domains or these potential areas for either focused intervention or much more preventative work. So when we think about in the United Kingdom, and I don't know precisely what has happened in Lithuania, but we obviously our government introduced a furlough scheme to protect people from the most dangerous impacts of the financial consequences of the measures to constrain and restrict the spread of the virus. Paulius has already mentioned domestic violence, and I think that's a really important area, especially as we look at the impact on women in particular. And then also looking at how these social isolation measures impacted on people's sense of entrapment. And so another key message from this paper on suicide risk and suicide prevention was, we again really implored researchers to try and enhance our surveillance, not just of suicide itself, but of the risk factors for suicide, and also to look beyond our standard suicide death data or self-harm registers. And so one of the things that we were keen to do, which I'll show you shortly, was try to then have some real-time data on not just on suicide and self-harm, but on our study looking at suicidal thoughts in particular, thinking that suicidal ideation or levels of depression or levels of symptoms of anxiety might be early markers of risk. Because one of the challenges with all our national registers or recording of suicide or self-harm is that there tends to be a lag between the data being, in the case of suicide deaths, there tends to be a lag, and when the deaths happen, and then them being registered and us being aware of them. So the problem is that when governments or clinicians or whoever it is trying to respond most effectively, our response is often hampered by the fact that the data are coming too late. Now, so what I'm going to move on to then is some examples from the UK of us trying to monitor the impact on mental health, first of all, generally, and then the impact on suicidal risk in the context of suicidal thoughts, second. So again, during the summer in July, a group of people led by Matthias Pearce and Catherine Abel from the University of Manchester were able to harness or use this existing data set in the UK called the UK Household Longitudinal Study. But the advantage of this was, because it was an existing data set, they had data from before the pandemic. And then they were also able to basically also introduce a new data set or recruit a booster sample, and it allowed them, using the existing resources of this panel study, to track up what people's mental health was like before the pandemic, and then compare it to people's mental health basically 1 month into the pandemic in April 2020. And the key finding they came up with was that as early as late April, that the mental health in the UK population had deteriorated before the impact, or before when you compare it to before COVID-19. Now, one of the limitations of this study, it's a great study, is its focus on the GHQ, the General Health Questionnaire, which is this more global measure of mental health. So one of the things that we were keen to do in my research group was basically try to look beyond these global measures of mental health to try and get more specific markers, to include suicidal thoughts, to include entrapment, to include things like loneliness, and so on. So then in March, April, I convened some colleagues, and we secured funding from Samaritans, the Scottish Association for Mental Health, and another suicide prevention charity called the MindStep Foundation. And what we were keen to do was, as soon as possible after the pandemic had hit, and we secured ethical approval to conduct the study, we were keen to recruit a nationally representative sample of adults from across the UK, so across the 4 parts of the United Kingdom. And initially, we were keen to then do at least 5 follow-ups over the next 6 or 7 months. Now, we're continuing the study beyond. We've now completed our 5th wave of data collection. I'll talk mostly today, though, about waves 1, 2, and 3. And then our plan is to try and continue to follow this sample of individuals into 2021. So anything I'll say today, though, I can't make any judgment about the mental health of people before the pandemic, because as you'll see in the next slide, this presentation focuses on the period starting from the 31st of March. Now, in the UK, our lockdown measures started on the 23rd, or were announced on the 23rd of March. So it's 1 week into the pandemic, into our lockdown, I'll be reporting on. Now, we've asked people from the 31st of March to tell us about what happened to them in the week prior to the lockdown measures. So we do have some indication of people's mental health at the very start. So these findings were published in the British Journal of Psychiatry a few weeks ago. The paper and all the published findings are available online. And basically, the study received quite a bit of coverage, of media coverage nationally and internationally. So if I just give you some detail, what we've got here, this is a map of the UK, and just to say that this is our sample is representative of the different regions of the United Kingdom. Now, to put it into context about our policy context in the UK, I want to just say two things. So this is when I'm going to focus most of my presentation on, and this is when we were in the deep lockdown. So we weren't allowed to, we were told stay at home, keep the NHS safe, protect the NHS, save lives. That was a strapline across the UK. So most of what I'll talk about is from the UK sample. And then it's also worth noting that in addition to the 3,000 people we recruited for this UK sample, we've also got a second sample of people, which I'm not talking about today. We've got a Scotland only sample called SCOVID, and that's 2,500 adults, and we're tracking them as well over time. But most of the data is referring to this period. And basically, if we look at the demographics, it fits in terms of our weight. These are the weighted demographic characteristics. If we do, this is the UK sample, which I'm talking about today, and this is the second sample, which again we've got ongoing data collection with this as well. But the findings are focused on this sample here. Here, broadly representative. I mean, really closely in terms of, if you look at the quotas we use for age, sex, at social background and region of the United Kingdom, we're pretty good at basically matching these with our UK sample. So what do we find then? So what do we find in terms of the mental health and well-being of adults across that crucial period of lockdown? Now, if I just focus in first of all on symptoms of anxiety and symptoms of depression, what's really clear here is that if we looked at symptoms of anxiety, now people's symptoms of anxiety were really, really heightened at the start of the pandemic, and lots of other studies have shown that. But what is clear is you see this recovery now over the first 6 weeks of the lockdown period. Now, the percentage of people scoring within this clinically significant level of greater than 10 is still much, much higher than what you would expect in the general population in non-COVID-19 times. But there is evidence of recovery. If we look at depressive symptoms, it's relatively flat in that first 6 weeks. There's a slight recovery, but that's not statistically significant. So what we see here then is a decrease in levels of symptoms of anxiety and relatively stable levels of depressive symptoms. If we look at defeat and entrapment, they follow the similar pattern to anxiety, and we start to see this decrease, recovery. Now, even though they are improving in terms of their decreasing, again, they're still much higher than what one would expect in non-COVID times. If we then look at actual self-harm and suicide attempts in those 6 weeks of lockdown, now this is self-reported self-harm, self-reported suicide attempt, and we ask people about the previous week in each case. So of course these numbers are very small. So we've applied no fancy statistics to it because you just can't. But I think what's clear here though is there seems to be some indication of an increase in both self-harm and suicide attempts, in particular from wave 1 to wave 2, and then it's relatively stable between wave 2 and wave 3. So there's some indicator of of a detrimental impact of lockdown in terms of self-harm and suicide attempts, but we can't say anything with confidence there because the numbers are relatively small. However, if we then move on to suicidal thoughts or suicidal ideation, I think we're on firmer ground in terms of helping us understand the impact on sort of suicidal risk. So what's stark here and concerning is we start over the waves, the trajectory is upward. So although we're thankfully, it's only 8% of people who are telling us they're suicidal in the previous week, that increases by about 20% by wave 3. And what's of note is, if you think about this in the context of the depressive symptoms data and the anxiety symptoms data, so we see, remember, anxiety is decreasing, depressive symptoms are relatively stable, but we're now starting to see this increase in suicidal thoughts. Now, the reason we think we may be seeing those increases in suicidal thoughts is the suicidal thoughts questions are tapping into people's concerns about the future, about the financial uncertainty, the social uncertainty, and I think that's the reason why we're seeing the increase. Whereas when you assess symptoms of depression or symptoms of anxiety, to answer those questions, we tend to be focused on the past. So then if we just go into a bit more detail into some groups of people in terms of their risk of suicidal ideation, we start to see this same pattern which others have also reported. And it comes back to this idea I mentioned already, that we're not all in the pandemic together. And what's very clear across the 3 waves of the study is that young people, in this case aged 18 to 29, they are most affected. There are significantly higher levels of suicidal thoughts. And although in this slide with regard to gender, it looks like women are reporting higher rates and they are, that difference is not statistically significant. So the key message from this slide is young people most affected in terms of suicidal thoughts. If we then look at social grouping, socioeconomic grouping, so this is our indicator of social disadvantage potentially, we see a very clear finding that those from lower socioeconomic groupings have higher levels of suicidal thoughts. If we then look at ethnicity, now, the ethnicity findings have to be treated with caution because we have a relatively small proportion of the population of Scotland is non-white, so it's about 10%. So these are just based on less than 300 people. And it's also important to bear in mind that we're treating Black, Asian, minority, ethnic as a single group, and that's unhelpful. But nonetheless, we still start to see this interesting trend in which people from Black and Asian and minority ethnic backgrounds are reporting higher levels of suicidal thoughts at waves 2 and 3, or that is the trend. So again, it supports some of the other data. If we look at the impact of the virus itself in terms of deaths from COVID-19, it's consistent with that, because we know from the virus data is that people from non-white backgrounds tend to be more at risk of dying from COVID. If we then move on to people with pre-existing mental health problems, so before COVID-19, had you a history of mental health problems, we see a very stark graph here. So we look at wave 3, people without previous mental health problems, about 6% of them are reporting suicidal thoughts. And we've got this marked increase, it's over 20% are reporting suicidal thoughts if you've got a previous mental health condition. So it really illustrates how the impact of COVID-19 and the restrictions is really adversely affecting people with mental health conditions. We look at then other groups, and if we just focus in here, first of all, on wave one, what we've got here, at the very start of the pandemic, we asked people whether their employment status had changed. So had they lost their job, or were they put on furlough, or were they working to reduced hours or greater hours? So those whose employment status had changed, unsurprisingly, they have reported higher levels of suicidal thoughts. Similarly, those who reported that they weren't managing financially okay reported markedly high levels of suicidal thoughts. But in addition, these two columns represent people who had children in the household with them under 5. So if you were caring for a child under 5, you were much more likely to report suicidal thoughts at wave 1. Exactly the same findings for wave 3. So this trend is consistent across that first 6 weeks of lockdown that we looked at. Now, we also looked at another indicator, whether people had access to an outside space. So if you lived in a flat or in accommodation in which you did not have access, so you did not have access to an outdoor space, unsurprisingly, at the height of lockdown, your likelihood of being suicidal was increased. But what's noteworthy, I think, in addition, is it's relatively stable from waves 1 to 2, but then you see this increase, this marked increase at wave 3. So what that illustrates, I think, is the cumulative impact of COVID-19 on people's well-being, in this case as an indicator of suicidal thoughts. Now, we also looked at loneliness, and again, consistent with what else we found, in loneliness, young people aged 18 to 29 reporting the highest levels of loneliness, and really the older adults, again, really protected, consistent with what we found elsewhere with other measures of depressive symptoms, with suicidal thoughts, and so on. If we then look again at depressive symptoms as a function of previous mental health problems, we again see this consistent pattern, same as the suicidal thoughts, but these are really stark. So by wave 3, 6 weeks into the pandemic, if you didn't have a mental health condition, about 15% of people are reporting higher depressive symptoms, but it's almost 50%. It's recovered a bit, but still at wave 3, about 50% if you've got previous mental health conditions. Now, if we then move on and look at sticking with people with and without a prior mental health condition, if we look at defeat and entrapment, again, very consistent pattern, doesn't matter which wave you look at, people with previous mental health problems reporting significantly higher levels of defeat, significantly higher levels of entrapment if you've got a mental health condition. And that we know are important risk factors for the emergence of suicidal thoughts. The same if we look at social gradient, so social background, people from the more socially deprived backgrounds or the lower socioeconomic groupings reporting significantly higher levels of defeat and entrapment. So again, this consistent and concerning pattern that we're not all in the pandemic together with respect to our mental health outcomes. Paulius mentioned the Imd model, which I talked about last year. And all I want to just illustrate is, so in the model argues that people who are feeling defeated, if they then become trapped, they're much more likely to develop suicidal thoughts. So we've looked at this in some of our data from the COVID study, and we find clear evidence to support this. So we can see levels of defeat, of course, are associated with suicidal ideation initially, but when we look at the mediating pathway or the mechanistic pathway, it's what seems to be going on is if you felt defeated at wave 1, but then by wave 2, you had high levels of internal entrapment. By wave 3, you're much more likely to have higher levels of suicidal ideation. And this is after controlling for baseline suicidal ideation. So what it illustrates is, obviously consistent with the Imd model, defeat to entrapment to suicidal thinking in terms of understanding the pathway to the emergence of suicidal thoughts. Okay, so before I move on to the deaths by suicide data work that others have been doing, I want to just give you a quick glimpse into some preliminary analysis, some exploratory analysis that we've done right up until wave 5. So most of what I've talked about, or all of what I've talked about so far, is waves 1, 2, and 3. Now, we've just very quickly done some initial analyses up until wave 5, which includes the period up until the 7th of August. And now the concern is, so this is what I've reported in the earlier slides, but then we see this continual creeping upwards. And so even though this period here, we were not in lockdown, people's suicidal thoughts are still increasing. And indeed, basically, if you look at the age groups again, we still see the young people, this continuing trend of young people continuing to be affected, much more adversely affected than any other group. And the same, we've still got this consistent pattern that females slightly higher, but not statistically higher. What we've also done, I'll just leave I'll leave the UK survey for a second. I want to just present 3 slides about real people going through COVID-19. And this is another study I'm involved in, which is conducted and led by my colleague, Katie Robb at the University of Glasgow. And this is part of this qualitative study in which we've interviewed people over 2 times over the period of the lockdown period of the last 6 months, or not just the lockdown period, during lockdown and then after lockdown. But again, 3 examples here, which I think really illustrate this idea that this consistent message that I've been making. So where I just wasn't engaged without anything, no matter how hard I tried to entertain myself, to try and engage myself with something. Now this was during lockdown. It was quite hard actually. So it was almost like trying to grasp for a lifeboat in the sea, and you can't grasp onto one. Because it's like you're just being drowned by this sort of thing, this depression. It's a great illustration of somebody who's experiencing depressive symptoms and how that feels to them during lockdown. And then another case here, again, looking at somebody talking about feeling depressive symptoms, even though, more time with the family and more time outdoors, it does seem like every day you get up, yeah, it's quite depressing. 2 weeks ago, I was at my kind of lowest. I wasn't able to go out somewhere. Like I just felt as if I was trapped. So a really good example of illustrating the words of somebody who's feeling trapped, as well as the quantitative data I've just presented with regard to what feeling trapped means. And then a third one, again, this is somebody who's experiencing suicidal thoughts. I found it quite hard being at home all the time. I've had a couple suicidal thoughts a few times during lockdown, but it was probably nothing to do with lockdown. I probably would have had them anyway, but I feel like just my mental health's been struggling. Really, really, sad then. Yeah, he didn't go through, he didn't act, female didn't act on her thoughts, but she almost acted on her thoughts. And it was having a family around her that kept her safe. So thankfully, this participant is still alive. But what that leads in nicely to is the fact that if we look now at trends in suicide, this is a brilliant editorial published by Anne John from the University of Swansea in Wales. And this is really worth reading because what the take-home message is that overall, in the early period of lockdown and the early months of the pandemic, overall, most countries, there was reassuring data that the suicide rates did not increase. but there are some signs or some signals which are concerning, and I'll just come to one of them in a second. So this is a great, very brief editorial which summarizes where we're at in our understanding of the pandemic. Now, again, just a couple of weeks ago, if we look to Australia, to one part of Australia, Queensland, the key take-home message in this study is that there doesn't appear to be an overall change in the suicide rate in the initial 7 months of lockdown. So that was good news. Similarly, from the United Kingdom, from England, Lewis Appleby and his colleagues have been doing some real-time surveillance of the suicide rates in parts of England. And again, what they concluded in this period up until August, doesn't include the more recent period, that overall, the data were reassuring. There was a bit of an increase, but that was similar to what one would have expected from 2019. And that really, in that phase of the pandemic, there wasn't sufficient data to conclude that there was an increase. So that was reassuring. And what they concluded in that report was that thus far until August, there was no evidence of an increase. And that, but crucially, with important caveats, that we need to look at populations, we need to look at local areas, and we need to look at the longer term impact when the economic adversity is really taking hold. So that brings me then to quite concerning data. Now, it's important to highlight that these data from Japan, it's preprint data, it has not been published, but I'm pretty confident these findings are going to hold. So what they've shown overall is that yes, there was no, if you look at change in suicide rates, that there was no evidence of an increase before the pandemic, or during the state of emergency, during the state of emergency. But then you see more recently, in the last few months, this marked increase in suicide rates, in particular amongst women. So you can see this is a female suicide rate, seems to be increasing in particular amongst women. And then if you go into those in more detail, we see not only is it women who are most affected, but in both age groups, both genders, male and female. If we just focus in on female, look at this increase here amongst people under 40. So again, if you put these data together, women age 40 or age under 40 are consistent with our data on what's in terms of our young people being most affected by the pandemic, and if we look at suicidal thoughts. So just to try and bring this all to a close and have a couple of minutes for questions, overall, what this is telling us is we need to be vigilant. And one of the other things I was involved in, and it was published during the summer, was this editorial, which was put together, led by this International COVID-19 Suicide Prevention Research Collaborative. And what we put together here was things we need to consider when we're thinking about our planning our research. Now, although this looks pretty large, this slide on my screen, I bet many of you, this looks quite small if you're looking at this in your laptop. But I just want to draw attention to one key aspect of this research considerations. And it's when we think about how we talk about our research findings, when we talk about what's happening to the suicide rates. It's really important that we take a balanced approach and recognize that even if sadly the findings from Japan are coming out as suggesting this increase in suicide, and there's data, as Paulius mentioned, about potential increases in recent months of suicide in Lithuania, what's important is we balance it and recognize that there's never just one cause to suicide, and we should stay away from sensationalist headlines, and we shouldn't be making monocausal or single cause attributions, because usually what will happen is, and our data are supporting this, is that although COVID is a context in which suicide rates may increase, the impact of COVID is on people who are previously vulnerable. And so what we need to understand when we're trying to make sense if it transpires that the suicide rates increase is that we need to understand what is it that made people vulnerable in the first place, and that COVID has exacerbated that. And that will be partly to do with social disadvantage. If we think about women and the increased risk in women, that will partly be to do with potentially domestic violence, potentially the fact that women have, over the duration of the last 8 or 9 months, have had to disproportionately juggle family and caring responsibilities alongside working and professional responsibilities much more than men, and that those individuals from more socially disadvantaged backgrounds are having an even worse time of it. And if you've had previous mental health problems, it's even worse. So my very final slide then is that what I think we can conclude thus far from the pandemic is, without question, the mental health and well-being, not just of the UK population, but of populations throughout the world, has been adversely affected. But obviously, some groups have been more affected than others. Our data on the suicidal thoughts and that upward trajectory is concerning, and we need to really, really be vigilant. And although the early suicide data were reassuring from many countries, we need to be really cognizant or vigilant because of the data coming out of Japan and as well as other countries. And because actually what we need to also recognize is the impact of the pandemic. Not only will it be different within countries, it'll be different if you're in a high income country versus a low income country. And we need to ensure that we tailor our responses accordingly. But the very last point I would like to make is we need to be vigilant, is that we need to be doing so much more to protect the most vulnerable. I live in the United Kingdom, and I know that our young people and our adolescents, the kids going through school, are really having such a difficult time, have had such a difficult time. But in the UK, the waiting lists for those young people to get access to child and adolescent mental health services is disgracefully long. And those long waiting lists are contributing to the problem. Because my concern is that people who need the help now are not getting the help now, and those delays are risking people's lives, they're risking people's livelihoods, and they're risking our young people's future. Thank you.
So, wow.
You're quiet there. I thought my whole talk nobody had heard it.
Oh, we heard it, and that was, wow, very rich data and very interesting. And I wish we had 1 hour to discuss it, but we just have 15 minutes, so I just rush straightly to the question. So one part of the questions is about the age. It seems obviously from your data and from other studies that young people are among the worst affected. And actually, I think, especially in the beginning of pandemics, that there was, for understandable reasons, focusing on elder people because the virus was more deadly and they had to be more isolated. But what we see from data that young people are affected even more if we take into account mental health. Could you, so several questions in one. Could you speculate a little bit more of why young people are so much affected? And the other part of the question would be, do you have any data or about even younger than people that are under 18? What is the situation there? And also about the older population, why we don't see an increase in suicide ideation there? So it's 3 questions in one.
3 questions in one. The question with regard to the under 18s, I don't have those data, but I know in Oxford, there's a Professor Kathy Creswell is doing this study called the COAST-based study, which is looking at the mental health and well-being of children and adolescents and their families. And the early data that she has talked about shows that absolutely within that. So, and taking other data that I'm aware of, I think that the kids before puberty are probably okay, generally speaking. And then, as we see from more generally in mental health problems, we know mental health problems start to emerge after puberty. And there is a similar pattern, from my understanding of Kathy's data and other stuff I've seen reported, is it's that those 13, 14, 15, 16, that you really are, as we know from pre-pandemic times, that's such a vulnerable period of time. Now, the question then is, well, why?
Yeah.
And in that age group, and obviously in the young adults in our study. So I think the disruption, the lack of routine and sleep patterns, I think the disruption in sleep, I think is a huge issue, especially if you've had pre-existing mental health problems. And I think that the lockdown of schools, I just think wasn't thought through properly. And certainly in the UK, I wish we hadn't have done it. I understand why we did it. And I'm pleased that mostly in my country, we've kept schools open. So I think there's something to do with disruption in sleep and routine. There's something to do with that, especially that age group, the importance of seeing your peers. And even though they're so connected, obviously socially, in terms of social networks, I just think that the relative influence of your peers is so important at that age that these disruptions, I think, are really problematic. I think then there's also issues of the family context and this family stressors and dynamics at that age group are always intensified anyhow. And then you've then got this situation in which you are genuinely at the height of the lockdown trapped. And then with moving in through the kids who had their exams disrupted. I know as a daughter who had her exams disrupted, she felt really out of control and felt that she wasn't able then to prove her teachers right or wrong, because this whole opportunity of doing her exams and getting her grades was taken away from her. And then with the older population, the young adult population, I think you said this, Pauline, already, is especially with the young women, is they're most likely to be in the hospitality sector or the caring professions. And in the hospitality sector, their jobs have been disrupted, the uncertainty, losing their jobs, as well as then if you're in the front line in the caring professions, you're actually dealing with death front line. And I think that stress of that has really impacted. So I think there's no one answer,
Yeah.
but I think it's along those lines is what I would assume.
So what is protective? What do you think about older people?
Well, I think there's a bit of, and not quite the sort of war spirit, but I think there's something about you're much more so at older adulthood. I think because you knew that your risk of the virus was of death from the virus was high, I think that you really recognize that you had to take these measures to protect your physical health. But I also think there's a bit of later in life that your social networks are much more stable and probably smaller. Well, they will be smaller. And I think that then that the impact that and your family supports are more important. And although there was all these restrictions, I think there was just some sense of which it just seemed that if we bed down now and we can stick it out, things will be better because because you've got that experience with life, recognizing that nothing is forever and that there is hope around the corner. I think in a younger age group, you actually we're much more difficult at thinking that through, because in that young adult population, my God, it's like I can't pay my next bill, or I can't get that job or opportunity. So I think there's a bit of wisdom with age, which I think help things.
And could it be also, just to share my own thoughts about this, that, thinking about young people, could it be so that their social life is much more disrupted because when you are older, you're probably more settled.
Yeah.
And if you have family, kids, and then you lock down together. But if a young person so used to go out, travel, and that's the things that are not possible.
Yeah.
And yeah. Mhm.
Yeah, no, I agree. That when I said the social networks or social life is more stable in older life, that's exactly what I meant. Exactly, absolutely. So yes.
Yeah, and I'm thinking that at least in Lithuania, and see some lack of empathy for the experience of young people, because it seems for general public, well, it's nothing. Just you have to stay
Uh-huh.
at home, use your messenger and Facebook, and you are happy. But we can see from this data that this may be overemphasis on young people living virtual lives, that when this real life is disruptive, we can see this consequences.
Yeah, no, I agree entirely, and that's why the messaging, the government messaging around this is so important. Now, I'm proud to live in Scotland, where our First Minister, Nicola Sturgeon, she has been an amazing communicator about the pandemic. And she has always been really clear about we do not blame young people. Whereas in England, in some cases, I sadly saw a lot of ministers coming on blaming the young people. Why couldn't the young people stay at home? What's the problem? Whereas exactly the point you've just made, Paulius, is that the impact on them it's so great, and it's all about the way you get people to adhere to guidance is not to punish them and not to beat them over the head, metaphorically obviously, but rather to promote this sense of community connectedness, to promote this sense that your actions will save other people's lives. And that's a bit was so important, because if you think about it, over the last 10 or 20 years, certainly in Europe and in the United States, in Western countries, this whole narrative has been kids, young people, they're just nothing but trouble. Oh, they do all these bad things. Instead of going, actually, what they're doing is all developmentally appropriate.
Yeah.
And their risk taking is about moving their lives forward as well as moving communities forward. So I
Yeah.
agree.
Yeah. Can we try to look into future, and about the longer, that there's a question about the longer impact of pandemic. So one of our participants asked, okay, so that's the present situation, but maybe we will see the bigger impact in 2 or 3 even years.
Oh, yeah. I mean, I think that even though obviously 2021 hopefully will be all about vaccines and getting back to some normality, we're only starting to see the economic consequences. Um, yeah, so my concern is the there we could have this generational effect once again of young people carrying their risk, and I do think the damage that has been caused to young people potentially, if we don't act more and do more now about getting access to services, supporting them academically, supporting them into the workplace, that we will see this longer term, which will last 2 or 3 years. Because remember though that, and I don't know the specific data for Lithuania, but before the pandemic, young people's mental health has been deteriorating in the UK and the United States and elsewhere before the pandemic. So levels of anxiety and depression were increasing before the pandemic. And this is just going to sadly be this exacerbating effect, plus now the economic consequences. And so, yeah, I am concerned for the next 2 to 3 years.
Okay, I think we go for the last question, very specific one. It's about, did you take into account, you know, seasons, yearly seasons, because we know that suicide, there is a fluctuation depending on seasons. And when you were, maybe the increase in suicide thoughts was just seasons effect.
I mean, very possibly, very. That's we obviously we couldn't take into consideration seasons,
Yeah,
right?
yeah.
Short answer. But one would have expected, though, so where the increase. Remember, these increases were happening over a 6-week period. So the most of those data
Ah,
I showed you is 6-week period.
yeah.
So in the UK, our seasons don't change that quickly. Right? But I think when we look at the suicide data, which at the end of the talk, I know certainly Lewis Appleby in the English data, that was all taken into consideration. And the same, I think, and the same will have been the case for the Australian data. So yeah, these are, so it's an important point, but that doesn't explain my suicidal thoughts.
Yeah.
Data.
And, and actually, when we are looking at the suicide data in Lithuania, we also take it into account. So we compare like July 2020 to July of previous years. So we take into account seasonality, and we see that there is an increase, a slight. Hopefully, it remains slight or vanishes, but we can see. That was wonderful. Thank you so much, Rory, for your time and for presenting this very, very interesting data. So thank you again.
And thank you to everybody who listened. And unfortunately, I just can't stay for the rest of today, sadly, but it looks like a fantastic rest of day program. So good luck and goodbye from Scotland, as they say in the Eurovision.
Bye-bye.